First up, we have Megan. Megan is a researcher on the health systems team at the Institute for Health Metrics and Evaluation at IHME. She has a master's in health metrics sciences from the University of Washington and comes with a bachelor's in community and environmental sociology, so bringing a pretty interesting perspective. Really excited to hear about her work on human resources. Thank you.
Yeah, okay.
Okay.
Do you want to use this instead?
I'm thinking about what's the easiest. I think this is better for my broken finger. Hi, this is Megan. I'm really excited to go through my presentation about the sex composition of the global health workforce between 1990 and 2022, with a particular focus on the role of female health workers. Okay, and this will be the overall outline of my presentation, and we can start off with some motivations. Okay. So it's very important to measure the supply of the global health workforce and country level health workforces to ensure that the health system has a sufficient supply of health workers to support the needs of the population. However, it's also really important to describe the composition of the global health workforce to make sure that policies are appropriately addressing the needs of the health workforce if they have differential needs based on the composition. So the whole point of this presentation is to produce sex-specific estimates of the global health workforce in order to formulate policies that adequately address the sex-specific needs of female health workers. Some of those needs relate to disparities in attainment of leadership positions and specializations. There are also increased levels of violence among female health workers, and also differences in the limitations of caregiving for health workers that female health workers don't receive adequate resources for. But one of the limitations of the existing research is that there is not a very consistent existing set of estimates by sex, cadre, geography, and time simultaneously to facilitate international comparisons. So the aim of this research is to estimate the global workforce and distribution by sex across 21 cadres by sex. And for the purposes of this presentation, we will just focus on physicians, nursing personnel, and all health workers broadly. And this aligns really nicely with some of the international agendas that prioritize gender equity, including the SDGs. Okay. The data sources that I leveraged to produce this research project fall into two buckets broadly. There are population-based surveys and censuses, and then there is administrative data usually coming from the WHO Global Health Statistics Database. And you can see broadly there's high levels of data coverage for both surveys, censuses, and tabulated data from the WHO, and they include both densities and sex shares. Densities are described as the number of health workers over the total population per 10,000, and our sex shares are just simply the proportion of the health workforce cadre that is female. And you can see broadly that we have higher levels of coverage for aggregate densities than sex shares. But there are high levels spanning between 1980 and 2022, fueling our estimation in 7 GBD superregions, 21 regions, and 170 countries. One of the notes that I would add about the differences in the types of data sources being utilized for the sources are that population data sources are prone to limitations due to sampling. However, the administrative data being reported from the WHO's Global Health Statistics Database is prone to errors related to double counting, lags in time, and reporting only public sectors. So it's known biases that need to be adjusted for, which you will see in our methods. Okay, perfect. And here's our modeling strategy that I use for the estimation. We start off with data extraction, which is what I just touched on in the previous slide. Here you're seeing that we are grabbing or extracting data from the WHO, the administrative data, in tabulated data source. And then we also have individual level data coming from population samples in surveys and censuses. The next step in the estimation process is occupation mapping, which only involves the individual level data. And occupation mapping involves taking self-reported occupations from the individual level data and crosswalking it specifically to the individual occupation coding system that we reference for measuring all of the health worker cadres of interest. The reference occupation coding system that we use is ISCO 08, which is the International Standard Occupation Coding System, and it's the most recent version. However, we accept individual level data from older versions of ISCO, less granular versions of ISCO, and also country-specific coding. So there's lots of mapping going on. The next process in the estimation steps are using that mapped individual level data to perform adjustments on the WHO. This is using a standard crosswalking process from the GBD, the Global Burden of Disease, which is a big project from the institute that I work at. And this adjustment is based on network meta-regression. The next step in the estimation process entails occupation splitting. So this is based on intermediate models run using spatiotemporal Gaussian process regression. And the distribution of those estimates are used to split aggregate occupation level data that is either includes multiple health worker cadres or includes cadres outside of the HealthWorks to identify only the health worker cadres that we are interested to include in our estimation. And then we run a series of models to produce estimates of the sex shares for each cadre, and that is also run using spatiotemporal Gaussian process regression, S2GBR. And then the process involves applying the aggregated health worker cadre densities and squeezing that to an overall health worker envelope and applying the sex ratios to produce sex-specific health worker densities. All right, now we can look at some results. So this is a figure describing the percentage of female workers in each cadre of interest between 1990 and 2022 by GBD super region. Some things that I would highlight here are that the global share of female workers across all health workers has increased during this time period, along with every GBD super region. For all health workers. However, the same trends cannot be seen in nursing personnel and physicians. Nursing personnel has been consistently highly concentrated as a female-dominated occupation over this time across super region and globally. And physicians have noticed decreases in the share of female workers between 2010 and 2020 for almost all of the GBD super regions and globally. Next, we can look at some country level estimates. This is describing the female share of all health workers among the top 20 most populous countries in 2022. And you can see that the female percentage of all health workers ranges from over 80% in Russia to under 30% in Pakistan. Similar findings, there's a substantial range also among physicians during this time period among the 20 most populous countries. Here, the female share of physicians is above 70% in the Philippines and under 20% in India. And there's much less variation among nursing personnel during that same time period. And now we can look at the sex-specific densities that are being produced. Here you can see increases in the level of the densities for both sexes for all health workers between 1990 and 2022. However, I would note here that the ratio of change between men and women is not consistent. So the growth is faster among women for all health workers. And if you look at the same plot for physicians, you can see that the growth is much more comparable during this time period, indicating that the all health workers envelope is increasingly becoming more feminized during this time period, but the same it cannot be said about physicians. And similar findings to the overall health worker envelope here are found, indicating that the density of female nursing personnel has increased between 1990 and 22. However, the densities have remained relatively consistent for males during that time period. Now we can take a look at a little bit of a different plot. This is a comparison of GDP and the female share of workers by cadre in 2022, a cross-sectional. And here you can see that higher levels of countries with higher levels of GDP have higher percentages of female health workers among all health workers. And similar findings are found among physicians, however, to a less extent. However, I would note also that the nursing personnel is very consistent across levels of GDP, indicating that the occupation is consistently dominated by female workers, regardless of GDP levels. And what I would note also is that this finding suggests that the auxiliary cadres are also fueling the corresponding relationship outside of physicians and nursing and personnel, because it doesn't align exactly with the overall health envelope. Okay, now we can talk a little bit about some of the takeaways from this results. There are distinct sex compositions stemming from different histories of occupational segregation across the occupations that I talked about. Physicians and nursing personnel have very different histories that contribute to the predominance of females in nursing personnel and not in physicians among most countries, though that is changing over time in some locations. This also offers evidence of feminization in the health workforce globally, particularly among auxiliary cadres outside of physicians and nursing personnel. And third finding that I would highlight is that the supply of health workers between 1990 and 2022 has increased consistently throughout COVID. And there are many reasons that could contribute to that, but also is likely going to cover or conceal some of the country level trends that are in disagreement with that. Some limitations to this study are the binary categorization of sex, which is reflecting just the input data both from the WHO and the individual level data sources I used. Also, the standard occupation codes restrict the estimation of some distinct professions and subspecialties. Next steps that I would be interested in pursuing include expanding the analysis to include additional characteristics about workers, including the number of hours they work and their sector that they work in, because it can affect the quality of their experiences. Another step that I would be interested in is looking at the informal labor force participation and how that how informal labor is contributing to the care that people give as health workers, and also the association between health workforce composition and health system performance overall. I would like to thank you so much for your attention, and I'd also like to thank my advisor, Dr. Hackenstad, for attending this and supporting me throughout this process. Does anybody have any questions?
Okay, I have so many questions, but I'm not going to take over the conversation yet.
Thank you. Very interesting presentation. Santiago from Argentina. You were mentioning that one of your motivations was related to equity.
Mm-hmm.
And in Latin America and Caribbean, there is a report by CEPAL that I don't remember if it was 60% of the healthcare workers are females, that is growing, but they measured the gap on the salaries. Mm-hmm. And the gap in the salaries is increasing in Latin America. So more women are coming to work in the healthcare sector, but we are paying them less than to the males. I think that is an interesting question for the future steps to see worldwide.
Oh yeah, absolutely. I think that's a lovely complement to this type of research, is that having readily available sex distributions for the health workforce complement that type of work really well. And it's a great way to show that devaluing of female labor, which is really common for the health workforce. So thank you. Great point.
Hi, thank you. My name is Amy Paul from VitaWave. I wondered if you could say a little bit more about the auxiliary occupations and if there are any trends there in, does it, even though we're seeing not a lot of movement in physicians, is there still a professionalization that's happening if they're in more specialized roles? Like what are some of the things that are happening in those auxiliary positions that are kind of driving the all health worker trend?
Yeah, I think that's a great point. So some of the key cadres that are not included at this point in the presentation are community health workers, dentistry personnel, and pharmaceutical personnel are also of key interest. And I think that your question is relating to the all health worker envelope and the interest in the increasing feminization of that. That is variable based on the types of cadres that we are considering. However, I think one thing that I would think about are the cadres that are traditionally devalued in terms of salary or professional responsibility and licensure. So if you would consider like pharmacists and pharmaceutical technicians, you would see increasing feminization in pharmaceutical technicians or pharmacy technicians or dental assistants relative to their dentist or pharmacist counterpoint. So you increase female labor in roles that are traditionally less valued in terms of like compensation. Does that answer your question? Much higher concentrations of women in more auxiliary roles or complementary roles where they are working with another counterpart for all of their responsibilities.
I know I personally have a dozen subsets of this data I would love to see, but particularly the community health workers, given some of the changing policies. So I'm walking and going to this question at the same time. So in Ethiopia, they're now talking about revamping their model household program because of the devaluing of the female leadership, they didn't feel like they were getting enough effect. So now they're bringing in men into that program. And so that's going to change the composition, but also the implications of what they're trying to do. And anyway, lots of follow-on questions there. Comment, not question.
Hi, Megan. I also from Brazil. Thanks for your presentation. We have a project also funded by the foundation that has a specific objective aim to try and understand what is the relationship between gender dynamics and the performance of health system. And we are discussing a lot about what is the mechanisms, what explain the relation. And my question is in this sense, because we are making different literature reviews, trying to find evidence to connect the female composition, the feminization of health workers, health professions, and how is the main drivers in your opinion? What is the mechanism that explain that a high proportion of females in the health services composition influence the performance of health system? Is this more linked with maternal and child outcome, or in your view, it's an overall health system? Thanks.
Yeah, I think that's a great question. This isn't something that we've investigated or interrogated too heavily at this point. So I would want to look at it more before I was able to give any indication, but I think it's a great area to look in. I would assume that the quality of healthcare for specifically female-related healthcare, or generally female-related healthcare, would be, so pregnancy care, I think, is something that we would be interested in. But I think it needs more interrogation before I can speak on it. Thank you.
Just another very quick question. So I'd like that to be very interesting if you can explore, for example, you are doing it in Brazil, try to explore this difference by different level of health system. For example, our main focus will be on primary health care. And maybe when we disaggregate this for Brazil, for example, we can see huge differences, especially when we compare the workforce in primary health care and at hospital care. Are you planning in your studies also disaggregate this by different level of system, if there is public or private composition of this workforce?
I think some of that is more feasible with this data than other components. I think location of service, like hospitals versus an outpatient setting, would be pretty tough or impossible for the type of inputs that we're working with. However, sector is something that we're considering going forward with. So that would be a more feasible private-public split.
Okay, I think we have to wrap this up. Thank you so much. I really appreciate it. If we can give another round of applause.